Now moving towards our second session, which is of pulmonary imaging in clinical practice, would like to call Dr. Richa Gupta, ma'am.
Good evening, everyone. Without wasting much time, I shortly introduce Richa ma'am. She is at present Professor and Head Department of Respiratory Medicine and at CMC Vellore. She has many credentials to her name, and over to you, ma'am.
Thank you so much. Good evening, everyone. And it's a pleasure as well as an honor to speak in front of your mentor and your teacher, Prasad sir. Thank you, Sanjay, and the entire team, Breathe Easy, for calling us all the way and making us a part of this 12th respiratory conclave. In next 20 to 25 minutes, probably, I would take you through a journey of clinical cases and to see what all we can order in terms of imaging when it comes to pulmonary imaging. So the most important investigation for a pulmonologist is imaging. We do rely lots on the imaging. The various types of imaging is, first thing is the chest X-ray, which is really, really important. It becomes an eye to us for looking into the patient's disease condition. Then lung ultrasonography has come up a very, very big way. Say 20 years before or so, it was considered that lung ultrasonography or an ultrasound is meant only for pleural effusions and related, but it has crossed past those things, and now it can be used for parenchymal lesions as well. We have CT scan, PET scan, MRI chest, and I wrote it 2 times. So we'll just look into one by one how and each of these investigations help us. What is the advantage of chest X-ray? Something is easily available, cheap, but there are radiation and rapid results. As soon as the image is taken, you can see that, and it can be done bedside. But at the same time, the disadvantage is that it has limited specificity and sensitivity. And when I say so, I'll just explain you in next of my few slides. But at the same time, I would say still an important initial investigation, and it at the moment cannot be replaced by any of the other imaging we are talking about. Chest X-ray helps, and all of us who are sitting here will agree with this. So if you're able to make out, I don't know if the pictures are very clear or not, it's very useful to diagnose pneumothorax. You have a right lung lower lobe collapse, you have a right-sided pleural effusion, you have a right upper lobe collapse, right? But sometimes you have to be detective. The things may not be appearing as gross as it is on these X-rays, which are the classical X-rays I showed. Sometimes you have to be detective, and all thanks goes to, again, Prasad sir, who were very strict on us on reading the X-rays, and thank you so much, sir, for making us good in reading X-rays. Let's look at this case 1. Patient came to emergency department with dyspnea. I want some of the people to actually respond, otherwise it becomes very, very monotonous. What do you see in this X-ray? Of course, the pathology is on the right side. Anybody want to volunteer for that? We don't have much of the time, so quickly if we can do. Yes, Swapnil? I won't say that this is the air and the diaphragm, because you could see some, the markings you can see. But yes, there is a pleural effusion is there. All I can see is the cardiomegaly is there. Agreed, patient has come. But what do we missed on that? We have to be detective. Look at this area. So incidental diagnosis of an acromion clavicular dislocation, right? That is why I said at times we have to be detective. Look at this patient who came to OPD with cough and expectoration for 3 weeks. Does it look normal? Everything looks normal? There is something. Okay, without wasting time, there is a safety pin in the trachea of the patient. Patient aspirated that, right? Another example, this is a patient who, okay, I'm not very sure if we are able to see it on the screen. Patient presented with breathlessness on exertion, and that was actually in an OPD, not an emergency department presentation. Workup was done, and echo also shows a pulmonary arterial hypertension. Do we see anything abnormal in this X-ray? Okay, so I don't know if you're not able to see, but in the interest of time, I would say, look at this foreign body which is there. So I asked the patient, did you had any procedure done at times? Do you have some? So he said that some in 2012, this is a 2025 X-ray, in 2012, he was very sick, he had some catheter insertion done. So this is the 2012 X-ray, and you can make it out that catheter was. So this was an IVC, central line guide wire was retained while inserting IVC in the patient. So sometimes X-rays are very, very good into the inside of the patient, but you have to be detective. Let me take you to another case. A 48-year-old male smoker who presented to us with history of cough, weight loss for 5 months, and some exertional dyspnea of 1 month. This was a chest X-ray. Quickly, Swapnil, you are a budding chest physician now. You've just passed your exams. This is a right lung collapse, and why did you say so? There is no mediastinal shift. Sir is not agreeing on that. So there is a homogeneous opacity, we agree, but this homogeneous opacity could be anything. It could be a large collapse, it could be a mass, but collapse only say there should be shift of the mediastinum to the same side, which is not there. It's kind of a fixed kind of a thing, or it could be consolidation, mass, or anything. And so the CT shows this. There is a large mass and there is an effusion as well. So do you agree that chest X-rays are good, but chest X-rays can be deceptive, right? Whatever, actually there is much, much more what we can see. Let's look into another case. A 56-year-old female, non-smoker, no history of biomass fuel exposure or passive smoking, had history of cough and mucoid expectoration for 6 years. Breathlessness also on exertion for 6 years, which used to aggravate seasonally sometimes, has been treated by multiple physicians with inhaled medication with partial relief only, and there is history of hospitalization for 3 times in last 2 years. Should it worry you as a physician? Yes or no? Yes, it should worry me. The reason being, pure OADs or obstructive airway disease does not behave like this. They should have improvement. There is no spirometry done for the patient, and patient is being treated like an obstructive airway disease or say asthma. So on examination, normal vesicular breath sound, but there were conducted sounds as well. So first investigations in an OPD was a chest X-ray. Does it look okay? Probably yes. The X-ray looks okay to me at the moment. And when the spirometry came, very clearly the people who can read, there is pure obstructive airway disease with no significant reversibility. Does the buck stops here only? No, probably not, because we failed to see the graph. And if you look at the graph, you would say that there is flattening of the expiratory loop. Now, as a physician, you should understand that there is something going wrong. This is not pure asthma. And then hindsight or retrospectively, everyone becomes intelligent. So when the PG came to me and this and all, I said, go back and see the X-ray. And then we look back this X-ray again and we can see actually there is something endotracheally. No, see, retrospectively everybody becomes intelligent. So I also became intelligent by saying so. Now, in this kind of a patient where X-ray, okay, it's coming normal, but there is conducted breath sounds on examination of the chest, and spirometry is showing flattening of the expiratory loop. What are you expecting? Most likely there is a large airway, some endobronchial or endotracheal lesion is there. Now, if that is the case, what is the imaging you are going to do? You would like to do a CT scan. So that is how the CT scan scores. So this was the CT scan for the patient, and we can say there is a large endotracheal lesion, and on coronal sections also you can see there is a lesion. So what does actually CT does? Any abnormality detected on a chest X-ray where there is a doubt, you do a CT scan. Now, selection of an appropriate CT protocol is guided by the question, the clinical question you want to answer in association with what is the patient presenting as a clinical history. The most commonly performed CT scan is the CT thorax with contrast. Sometimes people do it without contrast as well when there are some contraindication. So most of the indications say there is a lung nodules, cancer, you want to look at the mediastinal lymphadenopathy, vascular structures or pleural diseases. This is the CT scan which you would ask for. But in case you want to improve the ability to detect smaller nodules or say subtle abnormalities like thick interlobular septa, the walls of the cyst, or you want to look at the smaller nodules, ground glass opacities and etc. In that case, you would need CT scan which has thinner sections of 1 to 2 mm. This is called as high resolution CT scan, and it gives you high definition images of lung parenchyma, air spaces, airway interstitium and all, and hence it is required when you are suspecting there is bronchiectasis or interstitial lung disease, or a patient come who is symptomatic with breathlessness, chest x-ray is normal but PFT is abnormal. So these are the indication for HRCT. Again, CT pulmonary angiography is a little different way of doing a CT scan where you look where you want to give the contrast and look at the vascular structure also. Mostly it is done when you are suspecting pulmonary embolism or pulmonary arterial hypertension and the workup for that, or suspected aortic aneurysm. Low dose CT, Sani has already discussed. They are low dose. They are usually used for the screening of the lung cancer and for the patients who require recurrent imaging. So in those patients, we do LDCT in order to minimize the radiation-induced toxicities. Let's come back again to another case. A 40-year-old female, we will ask you what CT you would ask in these patients. A 40-year-old female, cough with expectoration for 6 months, hemoptysis on and off for 3 months, and breathlessness for 3 months. So that is the history. X-ray looks kind of normal to me. Anybody wants to see what kind of a CT you would like to do in this patient? There is history of hemoptysis, at least contrast enhanced CT scan, and that was the CT done for the lady. And you could see there was, it's going to come over here, there is an endobronchial lesion in the right main bronchus, right? So full marks goes to you, Swapnil, that we need to do at least contrast enhanced CT scan for this patient. Now coming to this 49-year-old male who presented to ED, gradual onset breathlessness for 4 days. See, the duration is very less. Worsened for 1 day. Saturation at the time of arrival was 80% on room air, and when Venturi was connected, it was making up to 94% only. X-ray looks grossly normal. So what is the CT you would like to do in this patient? Depends on what you are suspecting. CTPA is the right answer because you are suspecting pulmonary embolism in this patient. And if you could identify, it's easy to identify, you would just start tracing the vessels. Uses subsegmental arteries are not very well taking up the contrast, right? The subsegmental, as well as if you go up, you would see that even the main pulmonary arteries, both right and left, are not taking up the contrast properly, right? So this is a definitive case of pulmonary embolism. 66-year-old with off and on hemoptysis for 2 years, right? He's been having, but 6 days back had really, really large volume hemoptysis. The symptoms of cough with expectoration is also present for 6 years. Past history of TB is present. What is the most likely diagnosis? We are looking at aspergilloma or post-TB sequelae, say maybe bronchiectasis. So if you look at this X-ray, we could see, yes, there are increased markings, and that is what we would expect. So what CT you are going to ask for this patient? HRCT, he said. I will differ here. Yes, exactly. We would ask a CT pulmonary angiogram because I'm worried about this. He's been having small hemoptysis for 2 years, but large volume hemoptysis. I would like to look at the vessels, what has happened. So this was an HRCT for this patient, which certainly showed bronchiectasis in the right middle lobe and some in the lingula as well. You would do a sputum examination, which is certainly we have to do. But this was a CTPA done for this patient, and if you could follow up the things, you would say that we could identify the tortuous and hypertrophied bronchial vessels. So this patient will benefit by doing a bronchial artery embolization, provided you have ruled out active infection going on. Even in patients who are having active TB, and if they are producing lots of hemoptysis, bronchial artery embolization can be done. Look at the case 9, a 66-year-old with history of asthma for 40 years, cough with minimal expectoration for 1 year, exertional dyspnea for 6 months, and chest is basal Krebs. This is a PFT for the patient, spirometry, not the full PFT, which is almost absolutely normal. What is the CT you would like to do in this patient? Huh? In this case, you will need an HRCT. So the I don't know where the X-ray went off. So HRCT was done, and though, I will just go back. This was an X-ray of the patient which looked relatively normal, but patient was symptomatic. Though spirometry was also normal, but as chest was having basal Krebs, we suspected interstitial lung disease. And then if you would see, we'll rush fast. Though the X-ray was normal, we can see that basal areas, there is traction bronchiectasis, and there are features of interstitial lung disease in this patient. So putting up everything together, this is what the table I have made. I'll rush fast. Look at the case 10, a 33-year-old female with history of recurrent cough and hemoptysis for 1 year, mild right-sided chest pain off and on. So because X-ray looked normal, we did a CT scan, and when we look at the CT scan, it showed in the right lower lobe, it is showing one lesion here. I'll stop it here itself. So now this is a well lobulated, some cystic lesion is there in the right lower lobe, and the radiologist said that this could be a hydated. Now, having said hydated, they were not very confident, and that is the time when MRI will help. So an MRI was asked for this patient, T2 weighted images, and it shows that it has got hypointense membranes within, and then the diagnosis of hydated was confirmed. Similarly, 54-year-old male with complaints of intermittent dry cough, mostly nocturnal for 3 years. X-ray was done, which was abnormal, and he was referred to us for pre-surgery clearance. CT was done, which shows a paratracheal lesion, which is cystic, which is heterogeneous. It has both cystic as well as some hypodense lesion. So initially the radiologist felt that this could be bronchogenic cyst, but if you have seen bronchogenic cyst, it is mostly cystic, mostly fluid in density, but this was having those areas of hypodensity, and that is what, how would it help? Then T1 and T2 MRI weighted images were obtained, and though I am not an expert in MRI, because we do it very, very, in very selected cases, but the radiologist felt that there was some areas which has diffuse restriction, and hence this is not a bronchogenic cyst, but some tumor of neurogenic origin. So how does MRI helps? In pulmonary practice, we don't do it, but the data says for cystic fibrosis, especially the proton MRI provides better morphologic information and depicts disease activity from birth onwards. Especially it is important because the kids, they would be exposed for radiation from the beginning if we are doing a CT scan. We don't have it here, but in Germany, this is a protocol to do proton MRI when you are suspecting cystic fibrosis. There have been studies and meta-analysis where they feel that, CT, diffusion weighted MRIs can outperform CTs or PET CT in characterizing the SPNs. Similarly, in pulmonary hypertension, we don't do. Only 2 places where we do CT is when we have to differentiate, like say hydated cyst or cystic lesion, or in cardiac sarcoidosis is really played. So cardiac MRI protocol should be done if you're suspecting a cardiac sarcoidosis. Limitation is motion artifacts are there, low signal intensity, and moreover, the availability and the cost is a limitation. Coming quickly to PET scan, Sani has already said it is required for diagnosing, staging, and management of lung cancer. We'll move to case 12. A 46-year-old male under evaluation for pulmonary TB. So BAL and TBLB from the right lung was done because there were multiple nodules with train bud, and patient post-procedure complained of right-sided chest pain. An X-ray over here. Can we take off the clock, please? The X-ray was almost normal, and that was the time, because patient complained of chest pain, we did our ultrasound on the side, and we could see people who are doing ultrasound can identify this is a very classical sign, the lung point sign, which suggests there is a pneumothorax. Now, this patient was in a study where we were comparing ultrasound versus X-ray in diagnosing post-TBLB pneumothorax, and hence when there was a discrepancy between X-ray and ultrasound, an HRCT was done. Normally we don't do it, we believe on this, and you could see that such a small pneumothorax was there, which was missed by the X-ray but picked up by an ultrasound. 40-year-old female, symptomatic for 3 months, cough, breathlessness, loss of weight, loss of appetite. An X-ray shows homogeneous opacity, and the left side of the X-ray shows multiple nodules. We have a corresponding CT images also. We could say there is a central mass, there are lots of effusion. What is the next step you would do in this patient? Diagnostic aspiration, because effusion is there. It was lymphocytic exudate and everything negative. Sputum examination, we have to do for all our patients, negative. What is next step? What you would like to do? Bronchoscopy you would like to do because there is a central tumor. How about the patient is symptomatic, there is a large effusion? So there are ample ways you can make a diagnosis for this patient. What we did was we planned for a thorax, but ultrasound imaging was showing this, which was not seen on a CT scan. So there was such a multi-septated effusion. We just did an ultrasound-guided biopsy and got the diagnosis of adenocarcinoma. 39-year-old male, non-smoker, loss of weight and appetite for 3 months, breathlessness on exertion for 45 days, and this is an X-ray. If you could make it out, there is some abnormality over here. CT was done to find out, what exactly it is. The entire CT was normal except for very small effusion here. What would you do now? The radiologist said, we are not going to do ultrasound or CT guided biopsy because pleura is not thickened. And then ultrasound came to help. With the ultrasound, we were able to identify the area where we can put the trocar, induction of pneumothorax, and successful thoracoscopy could be done, identified as TB. It also helps in diagnosing, distinguishing between malignant and benign effusion, where you see that the pleura is thickened or the nodules are there, or you put in a patient with pleural effusions, always advise that you should look the abdominal organs always. So here is this liver, which is showing a big hypoechoic lesion, which is suggestive of METs. The last case, I believe, 16-year-old male presented with chest wall swelling and pain. This was the X-ray. We know it is abnormal. A corresponding CT image shows there is a lesion which is invading the chest wall as well. Day 1 in the hospital from the OPD, took the patient, did an ultrasound. I could see that there is a chest wall invasion. The biopsy done. Next day we had the diagnosis of primitive neuroectodermal tumor. So ultrasound helps a lot. It helps you in It has improved the standard of care, and I would advise everyone, no pleural procedure should be done without having an ultrasound probe in your hand. Now, I am a person who is coming from where we used to do pleural effusion based on our percussion skills on a chest X-ray and a lateral chest X-rays, but things have changed. Lots of litigations are there, lots of things are there. So please, please be careful, make use of ultrasound, and I can tell you, I feel that I can survive without a steth now as a pulmonologist, but very difficult for me to survive without an ultrasound. So it has, as I said, role of ultrasound has expanded far beyond pleura. We are using it as a screening tool for ILD and whatnot. So concluding, pulmonary imaging methods are fundamental tools for us, but each modality has a strong and weak point, which we should be familiar with to properly choose the methods. Thank you so much. I would also take an opportunity to invite you, if anybody is interested. We do yearly ultrasound workshop, which is scheduled for 1st and 2nd of August this year. Thank you so much.
Thank you, ma'am, for such a wonderful presentation, touching up all the modalities in a very simplified and clear manner. So, is there any question?
No, sir, that was a part of, no expiratory film was done for that patient. I agree what you are saying. It would increase in that if you're not able to see it. But the patient was, I feel when I have in my hand a modality which is least invasive, no radiation, bedside availability, which has much more sensitivity in diagnosis pneumothorax than a chest X-ray, then I would rather use that. But if it is not available, yes, expiratory scan would help in diagnosing if we are suspecting.
Ma'am, being a radiologist, ma'am, we have done for excessive hemoptysis. We can go directly for bronchial angiogram, CT bronchial angiography. The pulmonary angiography is a stage in we only image the pulmonary main pulmonary trunk and the right and left pulmonary arteries. In bronchial angiography, it is a little later stage at which we see the left atrium and the bronchial arteries. So it is a little different. When we order, we can directly write bronchial angiogram. So it will be better.
So what we do at our place is we ask equal contrast in both pulmonary and systemic circulation. That is how we do it, and that is why we are able to identify. Thank you. Thank you so much.
Thank you, and I think this session is over, and both the speakers were excellent, have shown their skills and had a good presentation. So
Thank you.
I close this session.
Thank you, Dr. Richa Gupta ma'am. To present memento to Dr. Richa Gupta ma'am, would like to call Dr. S.K. Pathak sir. Ma'am, are you? Sunil, memento and Patta. Dr. Richa Gupta, Professor and Head, Department of Respiratory Medicine, CMC, Vellore.